This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
My name's Tony Scott. I'm a Chief Investigator on OPUS and I'm a health economist as well. This session is really interesting because all the various parts of OPUS that we've seen this morning from primary care right through to treatment and post-treatment care, really to really address that, it is all about linking the data across that spectrum of care and also looking at the processes of care. So that's what this session is about. So our first speaker is Dr. Jo-Anne Manski-Nankervis from the University of Melbourne. Jo-Anne.
Thanks very much, Tony. Okay. So today I've been given the task of talking to you about data linkage and how we might be able to use data and data linkage to optimise osteoarthritis care. So I'm an academic GP and I'm going to take that lens as I take you on through a little bit of a journey to explore this. So some context. As I mentioned, I'm a GP, but I'm one of about 30,000 GPs who are working across approximately 7,500 general practices in Australia, many of whom are small businesses. And of course, in general practice, many of our patients do come in and see us about their osteoarthritis. We've heard today that osteoarthritis is estimated to affect maybe around 2 million people in Australia and projected to increase to 3 million in the next 10 years or so. And of course, we only see a subset of people with osteoarthritis in general practice, often when it's starting to cause some physical problems or pain problems or functional issues. And as Jane mentioned this morning, that accounts for 2.6% of all of our general practice consultations. But given that 2 million people attend general practice each week, that's about 52,000 consultations for osteoarthritis in the general practice setting each week. And this is in line with other estimates from other countries with some similar health systems to ours. So about 5% of people in the Netherlands will see their GP for knee pain each year, and about 4% of older people in the UK will see their GP specifically for knee osteoarthritis. So what is happening in general practice when it comes to management of osteoarthritis? What is supposed to be happening? And how can we maybe look at data or use data linkage to kind of address some of the gaps that maybe there are? So there was a bit of reference to these earlier today. So we have these guidelines released last year, very holistic guidelines for the assessment, diagnosis and management of hip and knee osteoarthritis. And I know that there are people in the room that were involved in helping to write that document. And of course, theoretically, if we put all of those beautiful recommendations together and we carry them out with our patients, we'll end up with very happy people that can jog again, like the person on the front cover of the guidelines. But of course, evidence and history, and a lot of experience already in the room, and people have referred to this already, there is, we know, a significant, very significant gap between what is in guidelines and what actually occurs in practice. And of course, there's many, many reasons for this. One of them, I believe, is the lack of integration of guidelines at the point of care. Obviously, there's things with time, patient preference and beliefs about osteoarthritis, clinical inertia, and of course, the access and cost to some of these recommendations that have been made. So let's take a little bit of a dive. Those guidelines tell us what we're supposed to be doing, what is actually happening in the real world. Well, this is data from Beach. Unfortunately, Beach is no longer being funded, but what this study was is it got GPs to record on a big pad of paper 100 consultations, consecutive consultations with their patients. And these all went to the University of Sydney and they were all coded and then were able to be analysed to find out what was happening for the management of certain conditions in general practice. And here we can drill down on osteoarthritis of the knee. And it's already been referred to a little bit today, but I think it's important to acknowledge that when we're talking about if exercise is something that we should be recommending to everybody with osteoarthritis, and physiotherapists are maybe the best qualified to help with that, we can see that the rate of referrals to a physiotherapist is about a quarter of that to an orthopaedic surgeon. Now, there's arguments that, well, a GP doesn't need to refer people to a physiotherapist, and that is quite true. But if we then look at what's happening with just even recommendations of physical treatments, really the rate also just falls shy of referrals to an orthopaedic surgeon. And so this is really here evidence of that guideline and practice gap. We had Max in his poster presentation talking about medications and opioids, and once again, really the rates of opioid prescriptions are pretty similar to also physical treatment. So we've got a lot of work to do in this area to understand the drivers for this, and then not just the drivers, what can we realistically do to overcome some of these barriers. So we have, of course, knee replacement surgery, and we also have the cost conundrum. Because whilst we know that total joint replacement, and we've seen it already with Philip earlier today, it's cost effective, particularly with people with severe knee osteoarthritis, it is only supposed to be for people that have exhausted some non-surgical options first. Then we have this issue of hearing that 1 in 5 or potentially more people might not get the benefits that they're wanting or expecting from their surgery. And even though we've got great evidence from people that are presenting at orthopaedic outpatients about how can we maybe predict those people, we don't have that back in the general practice setting. And we also know that the exercise therapy may reduce or delay the progression to surgery, but we do know that it's rarely provided. And a huge driver for this is cost. Now, we can say that surgery is a very, very costly thing, but we can also say at the individual person level, when they're pulling out their wallet, really physiotherapy at this particular point in time can be more expensive than getting your knee replacement done. And when we think about having 5 allied health visits a year for people with osteoarthritis, if they fit particular criteria to be eligible for GP management plans, that needs to be shared. And if you've got diabetes, osteoarthritis, hypertension, COPD, which is the majority of our people that have osteoarthritis, then those visits are spread very thin. And then next we have patient perceptions and knowledge. And there is a bit of a perception of physiotherapy equaling pain and maybe a bit less low-tech than some of those cool, shiny knee replacements and the promises of technology moving into the future. So Sam Bunsley and Penny O'Brien have done some qualitative work, and I think this quote sums it up a little bit. So the surgeon said that they wanted to wait until I was 10 years older. And I told him, because of the restricted ways of my knee, I wouldn't be able to exercise. And then I might come down with diabetes, which is going to be very hard to heal, and then cholesterol, and this will all make it very hard for me to walk. And if a surgeon does that knee replacement surgery now, well, probably in 10 years' time, they'll develop this special injection, and I won't need the extra operation for the replacement wearing out anyway. So we've got a lot of beliefs and patient perceptions as well, in addition to all the health professional factors that we've already discussed today. So what it comes down to is we have limited resources and we have uncertain outcomes. And so can data linkage maybe help us to identify those people most at risk of requiring knee replacement surgery in the future? And can we also identify people who are less likely to have a positive benefit from surgery, to help us to provide a pathway, not at the point where they've already been referred to the surgeon, but years prior to that in the community, in the general practice setting, so that we can have a pathway for management and maybe even underpin a shared decision resource for osteoarthritis management in general practice. A very quick segue into diabetes. Lots of commonalities with osteoarthritis. It's a chronic condition, often involves multidisciplinary care. Exercise and lifestyle modification is crucially important. And what we do have is a diabetes risk assessment tool that, when filled out, takes about 3 minutes, can put a patient into a low, moderate or high risk of progressing to diabetes in the next 5 years. And if they're high risk, they can access a program funded by the Victorian Department of Health and organised by Diabetes Victoria, to provide them with group sessions to give them knowledge about diabetes, how to prevent it, how to incorporate exercise and healthy eating into their lifestyle. So, is this an example that could be translated to the osteoarthritis setting? So in brief, if we want to do that kind of risk stratification, we need data. We need to think about data linkage. And of course, in the health system, we have silos of care, and as we also have in the data space, where we have to look at trying to link across those different data silos. So what we're doing in our program of work here at OPUS, and all the heavy lifting is being done by a fantastic PhD student here at the CRE Sham, is trying to say, can we look at general practice data? Can we do some data linkage and try to answer those questions that I brought up before? Who's at risk of progression to surgery, and who are the people that maybe may not benefit from that surgery, to inform our decision-making process? So we'll be using data from NPS Medicine Insight, which extracts data from over 600 general practices across Australia. And so there was about 475,000 people in that data set with osteoarthritis. Now, this is data from an electronic medical record. It's designed for clinical purposes, not for research purposes. And it doesn't contain data on important measures like function and quality of life. And that's why it's fantastic that we'll be able to do a linkage to the SMART registry at St Vincent's, which does have some of that really rich information. And of course, a concern that people always have, quite justifiably, is because these aren't research quality data sets in terms of the general practice ones, really how much missing data might be there, how much problems might that cause if you're trying to build a risk model. And so it's fantastic that we're going to be able to link to the joint replacement registry and be able to compare that to the data that is stored in the GP electronic medical records to see if those joint replacements are being recorded, and also to be able to access MBS, PBS and death index data from AIHW to also help with some of our validation that we need to do. So this is the process that we're going through at the moment, and we're about to get the first linkage for Sham to really start working on very shortly. I think one of the key things that going through this process, and many of you in the room would have been doing data linkage work already, is that whilst getting data sets linked is a laborious and time-consuming, a very long process, really in some ways it is dwarfed by a lot of the data preparation that has to occur. So cleaning all the data sets, developing the statistical analysis plan, working with statisticians, for example, right from the very beginning. Working hard to look at the data quality assessment and the pre-processing. So it's not a small undertaking. And of course, you always have to keep in mind what the end users are going to want from any models that are produced from this. So our GPs have told us, well, we want this to be embedded in our electronic health record. We don't want to have to add anything to it, so just build the model from what's in the record. We only want to know for a flag to be raised in our electronic health record if somebody's at high risk. We want to understand the model. We only want the model to include clinically meaningful factors. But we also want it to include important things that we know impact patients' experience and access to care, like their health insurance status, like their socioeconomic status. And we also maybe want such a tool to be available to people with osteoarthritis online to encourage them to understand their risk factors and maybe to bring it to the GP to have a conversation. Now, of course, if we develop a risk model and we work out what's our low, medium and high, the next issue is, well, what do you do with that? And there really has to be a pathway to be able to operationalise that. Now, we don't have the answers to that, and that's not what we're aiming to do. We're just trying to build the model to start off with, but we're hoping that the CRE will be able to provide us with advice onto that next step, what is most appropriate for these different people at different phases of their journey with osteoarthritis, because we also need to be able to balance access and cost. and we want the right people to benefit. So, what is the future? Well, really, we always started this project with the end in mind, and that is to be able to create something that can be used by people with osteoarthritis and their general practitioners to undertake shared decision-making to improve outcomes. And we've also decided from the beginning that this has to be something that can be underpinned by other technology platforms where we can provide that point-of-care decision support and that evidence at the point of care, and involving the consumers, people with osteoarthritis and the general practice in a co-design process to do that. So we're very early on our journey, but it's a really exciting one. And just as a result, I'd just like to thank all the people that have played a really important role getting to this point, as well as some of our funders. Thanks very much.